Good evening, Chairperson and the participants. I would like to thank the organizers and Association of Plastic Surgeons of India for making a part of this exciting module on burns. The topic assigned to me is inhalational burns. Nothing to disclose. If we look at the data, the inhalation component occurs in close to 15 to 30% of burn admissions. And why it is important? Because it impacts mortality as well as morbidity in the burn victims. And it is independent predictor of mortality, which increased by close to 20%. Besides, there is increased risk of pneumonia and respiratory complications in the patients of burns suffering inhalational injury. As the burn victim inhales smoke and hot gases, there are three distinct insults. One is the thermal insult because of the temperature of the inhaled smoke and hot gases. And second is because of the irritants present in the smoke and hot gases and various chemicals also, which cause injury to the lower respiratory tract. Besides, these constituents can be absorbed in the systemic circulation and cause various systemic sequelae also. The thermal component of the injury is primarily limited to the supraglottic part of the airways. This is primarily because of the low heat carrying capacity of the air in the upper airways, which acts as an insulator and it dissipates heat effectively. In addition, the glottis closes and prevents heat transfer to the lower airways. This is usually the case, except in case of superheated steam, in which there may be some injury to the lower respiratory tract. Otherwise, this is primarily to upper airways only. The thermal insults causes a lot of mucosal edema in the upper airway, like you can see here. But you should be very watchful because as you are giving fluid resuscitation to the patient, it rapidly progresses to airway obstruction. So in the initial part of the management, you have to look at the airway and see whether the patient needs intubation and intubate right there and then. The injury to the lower respiratory tract, that is injury below the glottis, is largely chemically derived, and it is because of smoke and chemical irritants present in the smoke, which include unsaturated aldehydes, formaldehyde, and halogen acids. They can cause direct injury as well as through neurogenic inflammation. What is neurogenic inflammation? It is because of production of neuropeptides. Look, the smoke has various irritants. They stimulate various sensitive nerves of the airway, which leads to the release of neuropeptides, which again cause inflammation in the lower respiratory tract. In addition, there is bronchial vasodilatation, which again increases the blood flow and increase seepage of fluid, and leading all of these act together to form pulmonary edema. Both airway hyperemia and edema in the lower respiratory tracts promotes the release of fibrinous exudate in the airway. And in addition, there is mucosal sloughing and there is inspiration of mucus. All of these factors work together to form cast in the airway. And then there is loss of surfactant and mucociliary escalator function. In addition, there is bronchospasm due to release of neuropeptides. These protein-rich casts are very thick and they are not easily expectorated. They will adhere to the airway, decrease the luminal space, leading to hypoventilation of the alveoli and pulmonary shunting. All of these will lead to systemic hypoxia, and which is usually seen from 24 to 48 hours after the patient is there with you. And over a period of time, there is decreased bacterial clearance, which can lead to lower respiratory tract infection, leading further to ARDS. In addition to chemical injury, the pulmonary damage has systemic pathophysiology also in burns because there is hypoxemia, hypercapnia, acidosis, and systemic inflammation because of release of various inflammatory mediators. In addition, there are soluble products of combustion, namely carbon monoxide and cyanide, and together they can cause a life-threatening situation, as carbon monoxide preferentially binds to ferrous in hemoglobin, and cyanide preferentially binds to ferric in mitochondrial cytochromes. Together, they will act synergistically and compromise the tissue oxygenation. So, how do you suspect inhalational burn injury from the history itself? There will be history of sustaining burns in enclosed spaces, and there will be history of unconsciousness also. And there could be delay in evacuation, leading to prolonged exposure to the smoke. The patient usually will have hoarseness of voice, cough, and may also have dyspnea, which is an emergency. The classical signs of airway burns are presence of facial burns, presence of singeing in the nasal hair, and also soot in the oropharynx when you ask the patient to open mouth. And there may be finding of carbonaceous sputum when the patient coughs out. The progression timeline could be fairly rapid. From hoarseness, it can suddenly proceed to edema as you start resuscitating the patient, and there could be airway compromise leading to respiratory failure. So, airway assessment assumes importance. For the supraglottic part of airway, you can easily assess by direct visual examination, and you can also do indirect laryngoscopy to look at the status of the epiglottis and the arytenoids, whether they are edematous, which can be detrimental in intubating in case the need arises. But however, subglottic part can be examined only through fiber optic bronchoscopy, and it has virtually become gold standard of investigation. The benefits of fiber optic bronchoscopy are it will give you immediate view of the airway. It can lead to rapid diagnosis of the injury as well as grading of the injury. You can directly see the soot drop deposits, erythema, edema, blisters, erosion or hemorrhages, whatever are there, and grade the injury accordingly. But the downside is it may not be universally available, especially in emergency setting. And sometimes the finding may not be apparent early. It may take 2 to 4 hours before the actual edema findings become apparent. Alternatively, serial chest X-rays can also depict inhalational burns. Like you can compare the chest X-ray taken at admission, which usually should be normal, and in case there is development of pulmonary infiltrates on day 2, chances are the patient has also inhalational burns in the lower respiratory tract. A better modality is the high resolution chest CT, which can reveal ground glass appearance in the involved segment. And for diagnostic purpose, it could be a bit better than fiber optic bronchoscopy because it will be able to detect the damage in the smaller airways like alveoli, which the fiber optic bronchoscopy will not tell. And also you can use this modality to grade the injury. And just to complete the list, you can do a nebulized technetium 99 or xenon 133 scan, which will tell you that which are the areas which are not getting ventilated and are affected by the inhalational burns. Systemic injury can happen when the products of combustion like carbon monoxide or cyanide enter the bloodstream, and the symptoms usually are non-specific in setting of inhalational burns. And to diagnose carbon monoxide intoxication, the fastest method is pulse CO oximeter, which is a setting in the pulse oximeter, which lets you know about the level of the carbon monoxide. In addition, you can send blood investigations like carboxyhemoglobin concentration. And in case it is more than 10%, there are chances of carbon monoxide poisoning. Cyanide has a very low half-life and it is very difficult to detect. But in case you are finding lactic acidosis along with the carboxyhemoglobin concentration greater than 10%, chances are the patient might also be having cyanide poisoning also. So a combination of ABG, carboxyhemoglobin levels and lactate levels can let you know and suspect cyanide poisoning also. So what to do in case of patient of inhalational burns reports to you? Securing the airways of prime importance, and you have to keep a very low threshold for intubation. So whenever there is shortness of breath, wheezing, stridor or hoarseness, and you find the patient is a bit combative and may also be having decreased level of consciousness, so early intubation is critical because as you start administering fluid to the patient, this edema is going to increase and you may or may not be able to intubate the patient then. And you have to anticipate airway compromise, and primary aim is to keep the airway patent. You can always do fiber optic bronchoscopy later on and decide whether the patient has lower respiratory tract burns and whether there is a need for keeping the endotracheal tube or not, which you can easily remove after 48 hours. As far as oxygenation and ventilation parameters are concerned, it is best to give humidified oxygen to prevent secretions from thickening, and it is better to keep head end elevated at 45 degrees. This will reduce the supraglottic part of the edema, and also it will minimize the pressure exerted by intra-abdominal structures on the chest cavity, making the respiratory effort a bit easier. You can also use steroids and diuretics in a very judicious manner on short-term basis only to decrease the edema. After airway is secured, then comes the fluid requirement, and some practitioners will try to restrict the fluid in an attempt to reduce pulmonary edema. And this practice has to be discouraged strongly because it can be counterproductive. There will be hypoperfusion, which will exacerbate the pulmonary capillary leak and will increase the lung lymph formation, and then overall again will lead to hypoxia. So rather, these patients require more intravenous fluid than normal patients, as opposed to Parkland formula figure of 4 ml per kg per percent. These patients will be requiring close to 5 ml per kg per percent of thermal burns. And however, you have to titrate the fluid need with the urine output and avoid fluid overload as well as underload. After securing the airway and charting the fluids, Next is how to manage the inhalation burn injuries to the lower respiratory tract. And it has been seen that bronchoalveolar lavage, rather whole lung lavage, significantly leads to shorter ICU and hospital stay in all the patients. Here you can see after the lavage, these are the proteinaceous casts which have been taken out. And they also lead to shorter duration of mechanical ventilation in these patients. And there is a reduction of mortality by close to 18%. So whenever possible, whole lung lavage should be added to the management of these patients. These airway casts are primarily made up of fibrin and mucus, and you can enhance their breakdown and make them easier to remove by using nebulized heparin, which acts as a fibrinolytic, and also you have to use nebulized N-acetylcysteine, which acts as a mucolytic, and combine it with pulmonary lavage. So all these modalities will act to reduce the ventilation requirement and also will reduce the mortality. You can also add nebulized epinephrine or albuterol to improve the bronchospasm. And as you know, there is compromise in mucociliary escalator. This will also improve that function. And in case you are unable to do repeated bronchoalveolar lavage, you can try doing chest physiotherapy with suction. And there are various techniques like percussive techniques along with cuffing techniques which can help to mobilize these inspissated mucus secretions in the chest. And you can also opt for postural drainage. The primary aim is to reduce the airway pressure and prevent atelectasis and pneumonias and ARDS, etc. These patients have a very high risk of developing ARDS because inhalation injury to the lower respiratory tract is compounded by hypermetabolic response of burns along with elevated carbon dioxide production levels. So there are specific techniques which are to be adopted in these patients. One is airway pressure release ventilation, another is high frequency percussive ventilation. We cannot go into the details, but the bottom line is both these techniques will help to augment impaired oxygenation and buttress expectoration, which is of prime importance in these patients. And there is extensive alveolar recruitment, which will improve the air exchange. And there are lower rates of pneumonia and ARDS when these particular techniques are used. Carbon monoxide and cyanide intoxication in case present can be rapidly fatal. So in cases where carboxyhemoglobin levels are more than 10%, it is best to give 100% oxygen with tight fitting high flow mask, or rather intubate the patient and deliver oxygen through that. And we can also quantify the carbon monoxide levels by measurement of carboxyhemoglobin on ABG on serial manner. And in case there is no clearance of these levels, then there is a case for using hyperbaric oxygen therapy when these levels are persistently high. Cyanide intoxication can be treated by using hydroxycobalamin 70 mg per kg, which is a precursor of vitamin B12. It will lead to formation of cyanocobalamin. Or you can use sulfur donors like sodium thiosulfate, which will lead to formation of thiocyanate. All of these will help to reduce the cyanide levels in the blood. So we have to be aware that whenever thermal burns are complicated by inhalational burns, these patients will require a prolonged care and most likely in ICU setting, and which also is likely to be prolonged. And they will require intensive fluid titration, and they will also require use of bronchodilators and other adjuncts to take care of the lower respiratory tract. And we have to supplement it by bronchoalveolar lavage and chest physiotherapy. In short term, these patients are at higher risk of ARDS and multiple episodes of pneumonia, but on long term, it can lead to tracheal stenosis and long term respiratory dysfunction. So these patients require long term pulmonary rehabilitation, nutritional support, and psychological care. To summarize, in case of presence of inhalational burns, early diagnosis and management is very critical. And these patients will require frequent bronchoscopy and monitoring of lower respiratory tract. And there are specific ventilatory strategies which you have to follow. Along with that, you have to follow burn care protocol. And so utilizing these and multidisciplinary protocol, there will be overall good results. Thank you all for a patient listening.